It gives me enormous pleasure to introduce three friends, three great trialists. Carol Hodgson, Hallie Prescott, Simon Finfer. They must feel like Christians being walked into the Colosseum with a smack group. We're going to dive into things right away. Simon, you have a lovely time at Noosahead every year, don't you? You go surfing. It's delightful for a man of your age. Why on earth should this audience give a toss about your clinical trials vanity projects?
Well, I was actually going to bring up my age, Peter, but since you have. So I'm very old. You're a young man. So I qualified in 1981 at the ripe old age of 23 and went straight into being a doctor with minimal supervision. And evidence-based medicine entered consciousness in the 1990s. So the early part of my career, there was no mention of this thing, evidence-based medicine. And what I realized was we didn't actually know what we were doing. We were copying what other people did. And if I can give you an example, we were taught that acidosis was bad. So in the average ICU, and this is in London, but I don't think it was different anywhere else in the world, we tried to normalize the carbon dioxide because acidosis was bad. And it was not uncommon for us to be looking after a patient who had a severe lung injury who would have 6 intercostal catheters in as we destroyed their lungs with a mechanical ventilator. And we killed a lot of people. And what I think our clinical trials is about is not entirely a vanity project. It's the fact that I realized that most of what I did, I was copying. I was taught to do something, I learned how to do it, I'd seen other people do it and they were comfortable with it, I became comfortable with it, but I had no idea if it was the right thing to do. And that is what clinical trials are about. And I was fascinated by the previous presentations and because a lot of what we've done has been, you can't possibly do that. Nobody's ever tried to do that before. Don't be so effing stupid. And all that kind of motivates some of us to want to do it even more. It was a matter of changing the landscape. And I think it's helped our patients.
Thank you. Hallie, moving on to you. Simon's a member of the ANZIC's Negative Trials Group. Is the clinical trial fit for task? Is the mighty p-value mighty, or should the p-value be the patient value?
So I largely do observational research, so I'm going to answer this as like a slightly different question because I'm not a trialist. But I think that the reason that research is important is I was struck by Phil Dobson's talk yesterday about the importance of having perspective on our problem and perspective on our solution. And I think that inherently our view as a clinician is limited to the experiences that we have with the own patients that we take care of, and that research is necessary to fill in those gaps so that we have a holistic understanding of the problem and a holistic understanding of the solution. So I'll give some examples. So most of my research has focused on long-term outcomes, what happens to our sepsis survivors after they leave our intensive care unit. And about 15 years ago, it was largely believed that as long as we got them through the ICU, that they'd go on to do well. And I think that reflects a couple things. First and foremost, we're optimistic about our patients, right? And secondly, the last time we see them is the day they leave the ICU, typically, when they're doing better. And so, because we don't see the patients after that, typically, we sort of fill in the gaps. We assume they continue to improve going forward. And it's only research that actually opened our eyes and told us that's really not the case, right? So around 2003, 4, 5, the first smaller cohort studies came out showing that people do really awfully when they follow people up at 3, 6 months, 1 year. We find that there's substantial problems in our survivors. But still there was resistance to this idea. Maybe those are just the sickest people, or that's that hospital. And then larger multi-center studies came out showing the same thing. So that really reframes the problem, right? This isn't just about surviving the ICU. It's about a longer-term recovery. And then in terms of understanding the solution, this is where I do think, clinical trials really do come in. And much of what we have learned over these past, 10, 15, 20 years is that these short-term physiologic endpoints that we see in front of us don't always translate into better outcomes. So we've talked about the FEAST trial where people got fluid boluses and initially they looked better, but they died more. And on the flip side, when we look at low tidal volume ventilation, people's oxygenation was worse, but they survived. And so if we only have our own clinical perspective, I don't think we have enough of a holistic understanding of our problems or our solutions to drive care forward. And so yes, I think that the clinical trials are necessary to objectively measure what is happening when we are delivering a treatment to patient to understand truly is that beneficial or harmful.
So let's take it as written that you've justified your jobs and your funding for another year. Well done. Good cognitive bias. Carol, the dark arts of getting research done. 85% of research trials or applications aren't funded. If 85% of our patients died, we would quit pretty soon. You then have to generate an appropriate question, get ethics approval, collect the data, talk to that, because I believe this is a truly creative endeavor that takes tenacity, grit, you name it, all those buzzwords.
Yeah.
Tell us about that.
Okay, Pete, I completely agree. So I think I spent the first 5 years of my research career being completely unsuccessful, to the point where I met with my boss and I said, no fellowship, no big grant, no program of research that I can sort of move forward on. And he said to me, you've got one more year. And I was like, oh, geez, okay, one more year. And he said to me, you're so busy, and maybe this speaks a little bit to some of what was being said in the first session, you're so busy doing, maybe you just need to focus on doing good work. Just do good work. So I broke that down a little bit and I thought about my strengths and what I'm passionate about and the things that I thought I could bring to the table. And I honestly think for me that was around functional recovery, physiotherapy, early mobilisation, and I really focused all of my effort on that one program of research, which was, as a physio, we're in a very privileged position. We get to see the patients when they're critically ill and at their most vulnerable. We also sometimes get to see them and follow them onto the ward and see how poorly they're doing. We speak to their families rely on us, they want to get them home, they want to know how they're going to be able to strong enough to get themselves home. And, so I was actually able to see a little bit of the trajectory of the recovery, and it reframed my question. So I think there's a couple of things I did at that point in time. I played to something that I was very passionate about and that I love doing. I surrounded myself with really good people, so I think that you absolutely can't do this. There's no I in team, and that's my program of research. It's the team study, so I had to have a really great team of people around me, and some of them are here today. I can't thank you enough. And then I focused on the patients and what I thought was going to be really good work for them, and I brought them into the question. So now we've actually got patients on our management committee, patients helping us form the questions, think about what are the important outcome measures, and really helping us tell the story that we can sell to funders.
Fantastic. I've heard academic medicine described as a pie-eating contest where the only prize is more pie. In other words, it builds and builds. And I've heard of Brandolini's asymmetry principle where it takes 10 times more work to refute bullshitters to produce it. How is the trialist of the future going to find time? And how are you going to counter every time a crackpot suggests you don't need to get vaccinated, try this wonder drug, perhaps vitamin C in sepsis? How are you going, for example, in the last 2 minutes, guys, anyone, what's the future of clinical trials? How do we make it happen?
Okay, Simon.
So I've been volunteered. Napoleon didn't want his generals to be brilliant. He wanted his generals to be lucky. Okay, so luck has played an enormous part in my life, and I'm a naturally lucky person. So just walk next to me, and you'll get lucky too. So we got really lucky. I'm just answering your question in a bizarre way. We got really lucky in that the Cochrane Injuries Group went out and did a meta-analysis and said albumin kills people. And we knew that 50% of people in ICUs in Australia, because we went out and found out, got some data, got albumin. So we were killing 1 in 17 people, apparently, by giving them albumin, according to Cochrane. So someone else handed us the question that needed to be answered, and we did the first ICU mega trial, and that was what got our clinical trials group off the ground. There is no such thing as a negative trial, as we all know, and even Peter knows that.
He does.
So we need Hallie, and we need Carol, and we need to work in teams, because the research that Hallie has done with Jack Iwaschner, and it's framed a whole new concept of, okay, we now understand that 75% of people with sepsis survive, and they have got major ongoing problems. So now we need to work out what can we do in the ICU to prevent those problems happening, what can we do in the hospital before they go out to make the problems less, and what can we do after the people have left. So the clinical trials, we have to think in terms of programs of research. We need the observational data. We need to know what's happening in our places. We need to, and then we need to design a decent trial, and then we do have to go out and sell it and get more pie.
Perfect. And in the last couple of seconds, isn't big data just going to replace the clinical trial, or is it going to enhance it?
So I think we have a real opportunity to embed some clinical trials within our data system. So, for example, the Australian New Zealand Intensive Care Society Adult Patient Database has started to embed trials. We're setting up an ECMO registry. We've already embedded trials, and I think that's the future of being able to run efficient, cheap, and well-conducted research, is to embed it into the big data.
Fantastic. Thank you very much.